Okay, so the idea now is to talk about nose bleedings, also known as epistaxis. So we'll call nose bleeding epistaxis, which is the more official name. So in the pathophysiology, or let's say what it is, it's bleeding from the nose that comes from especially two places. There is the anterior, which is more common and less severe, and there is the posterior nose bleeding, which is less common but more severe. The etiology is most commonly is local trauma or drying of the mucosa, but there is a list of causes you can see here, which are the most common causes of what we said, drying and local trauma. And the less common causes you can see here, atherosclerosis, problems with coagulopathy, coagulation, or thrombocytopenia. So sometimes if you suspect this, you can take PT, PTT, and CBC for platelets. Foreign body, you will some maybe see very malodorous secretions also, local infections like vestibulitis or rhinitis, hereditary hemorrhagic telangiectasias, they are the criteria to diagnose it, recurrent epistaxis, AVMs, family history, and etc. and etc. Septal perforation, which can cause be caused by trauma, it's a perforation in the septal cavity. It can be caused by trauma, a GPA, glomerular glomerular, oh yeah, I forgot the name, GPA, autoimmune, autoimmune, glomerulopathy with polyangiitis, granulomatosis with polyangiitis, yeah, I forgot the name. Okay, systemic disorder like liver disease and AIDS, tumors, uh, sometimes you will see bulging if you can in the nasal space. Okay, so this is the list, but again, the most common causes of what you saw here. So evaluation, when it happens, what the patient did, if there is any considered for history for coagulation disorders or drug that can be problematic like aspirin or heparin or warfarin. All of these are coagulation medications that cause increased coagulopathy or increased bleeding. For example, for patients who are taking aspirin for prevention of stroke, or for AFib patients that have high CHA2DS2, which takes DOACs, or for patients with, I don't know, recurrent DVT that takes a low molecular weight heparin, and etc. and etc. Even NSAIDs can increase the risk for bleeding. Okay, so physical examination, try to identify from where is the bleeding. Of course, when the patient bleeds, it will be hard, so the treatment and the evaluation should be done concurrently. And red flags is a severe one, signs of hypovolemia, anticoagulant use, cutaneous signs like telangiectasias, bleeding not stopped by direct pressure, and multiple recurrence, which hint you to some, it's maybe a potential cause like coagulation disorder and things like this, and hypovolemic shock tells you that the bleeding is severe. So interpretation of findings, like the list of causes we said, and test if you suspect a coagulation disorder or thrombocytopenia, take it. If you suspect a foreign body, sometimes imaging will be needed. Treatment, anterior epistaxis, you need especially to uh, push the area, push the nasal cavity. There is sometimes tools that you can use. If it's not working, you can also use a gas with a vasoconstrictor like epinephrine, like phenylephrine, sometimes epinephrine, sometimes tranexamic acids with lidocaine, so it won't be very painful. Sometimes a catheterization is needed, or electro, or using silver nitrate that can uh, like burn the area, burn the blood vessels. You can put it with you can put the gas with mupirocin or bacitracin. If you put a tampon, it's also an option. Putting a tampon that can expand in the nose with some mupirocin or bacitracin, so it won't cause infection. Okay, posterior epistaxis is more severe and is harder to treat. Sometimes they need to insert a gas to the posterior part. It can cause infections, or sometimes prophylactic antibiotic is given. It can cause reduction in oxygen, so sometimes oxygen therapy is given, and it's hard. Now, for bleeding disorder, there are a embolization technique and a laser technique and grafting. There are techniques that can be used for reducing the recurrent epistaxis that can happen in hereditary hemorrhagic telangiectasia. Okay, note that when his blood is swollen to the abdomen, to the stomach, it can cause irritation and vomiting of blood in these patients. Also, blood that is swollen can be digested, and there is a lot of protein in it. So when the protein is digested, it can cause ammonia production, and this ammonia for patients with liver disease can get to the brain and cause encephalopathy because it won't be removed by the liver. Um, yes. Okay. So sometimes for epistaxis patient, we tell them to try to don't get the head up but down, so the blood will go to the anterior part and not to the nasopharynx, and from there to the abdomen and to the stomach and irritate the stomach. So this was about epistaxis, anterior epistaxis, posterior epistaxis, red flags, causes, more common causes, more rare causes, and that is it. Thank you very much. This was from Mac Manual Professional Edition. If there are any correction or mistakes, please tell me, and that is it. This is just the Kesselbach area plexus, which is the most common cause or place for bleeding in anterior epistaxis. This is the plexus that can bleed, so we can apply pressure on this place especially. This is where anterior epistaxis can bleed from. Okay, that's it. If you have any concealed area for posterior epistaxis and anterior epistaxis, posterior epistaxis and anterior epistaxis. Woodruff plexus, sphenopalatine artery, Kesselbach plexus, anterior epistaxis. Thank you very much. If there are correction or mistakes, please tell me. And thanks for Mac, and that's it.